Professor Houston Kwa, President of the ESS, economists, ladies and gentlemen, friends, colleagues. I'm not speaking according to the theme today, but I think it's related because Houston posed some philosophical questions on stage, which is the determinants of quality of life. And we know GDP is probably necessary but insufficient. But another necessary but probably also insufficient factor will be our health. Right? After all, health is our biggest wealth. So as Minister for Health, let me now talk about health and how it drives welfare. When Houston invited me to speak this morning, I jumped at the opportunity, but not because of the theme, but because of selfish reasons. I'm hoping more economists will work for MOH. And we do need your help. Yeah. So today, speaking to a room full of economists, I'm inclined to confine myself to talk about markets and price, dollars and cents. But because I'm also health minister, I also need to talk about life and death, values and trade-offs. And suffice to say, to solve today's complex healthcare challenges, we need more economists, not less. Yeah, we need more doctors, we also need more economists. So here it goes. I would like to start with a simple thought experiment. That is, if a country had a significant absolute advantage in healthcare, and it decided that this shall be our main economic sector to drive employment and jobs and growth, what would happen? The country would build world-class hospitals. They train many doctors, nurses, allied health, and all kinds of talent, and they would go on to treat many patients. So good, meaningful jobs were created in abundance. Healthcare workers pay taxes, hospitals make money, pay taxes, government coffers grew. So far, so good. But very soon, the country realized that healthcare was not just an economic activity, but like transport, like education, like public transport, like education, it is also an essential service for society. For the lower income especially, healthcare needs to be subsidized, need to be accessible, need to be affordable. So this hypothetical country decided we need to subsidize healthcare. How to do that? So they scour around best practices in the OECD countries. And they realized almost every OECD countries subsidize healthcare very generously. They call up WHO, they call up UN, both of whom told them the same thing, which is universal healthcare is very important. And hence, this country decided, let's make healthcare free for all citizens. Follow the NHS. Then problems soon arose. Their Ministry of Finance discovered that the expenditure needed to subsidize healthcare was ballooning. The taxation they collect from the healthcare sector was not enough to pay for the subsidies. So one way to solve this problem is that why don't we raise more revenue by attracting foreign patients who will seek healthcare in our country, enjoy our excellent healthcare services. They pay full hospital bills without subsidy, and therefore we will make money. Hence, they promoted medical tourism, and it was good business. But then problems were brewing on a separate front, because for the locals, healthcare is free, the demand became excessively high. Doctors would order more tests and treatments. After all, the patients don't have to pay. Patients too happily accept those prescriptions. In fact, patients will visit several doctors for the same illness since it's all free. And we know this is happening in some countries. So with demand ballooning, capacity limited, patient waiting times got longer. Service levels fell. The situation was aggravated because many top doctors and healthcare professionals, they prefer to work in the sector of medical tourism because that's where the financial rewards were. Citizens began to notice the disparity in service level between what they are experiencing and what the medical tourists were experiencing, and they were not happy. So I shall stop my hypothetical scenario here because it just gets messier. It suffices to say there was no clear path to a happy ending. So the basic point I want to illustrate is that the healthcare sector is complex. And having spent many years in the public service, moving from ministry to ministry, I find healthcare by far the most complex system I've ever worked in. Like all public services, it is useful to examine healthcare from an economic lens so that we know how best to regulate, to govern the sector. In that regard, I will talk about three of the most salient economic challenges in healthcare today. Not exhaustive, but I think these are the three that I think most salient. The first and the most basic of all economic objectives is to match demand and supply of healthcare. But in healthcare, it doesn't work like a Marshallian demand-supply curve, where the price just moves to where demand cuts supply and problem solved. You've got equilibrium. It doesn't quite work like that. Supply of healthcare is limited and sticky, as it takes years to train healthcare professionals and build hospitals and facilities. Demand for healthcare, on the other hand, is potentially unlimited and very fluid. It's fueled by subsidies, but also emotions such as fear, anxiety, and love, and often untamed by price. Some describe the task of allocating healthcare supply and demand as managing, they call the iron triangle. In monetary economics, there's this trilemma. In healthcare, there's also the iron triangle. And these are the three desired outcomes for healthcare. You want it to be affordable, you want it to be high quality, you want it to be accessible. The final analysis, just like monetary economics, is that healthcare authorities can achieve only 2 out of 3. You've got to sacrifice 1. Something has to give. In Singapore, we try to juggle all 3 and try to achieve most of all 3. And whatever we don't achieve, add up to 1. How a nation resolves this mismatch is a key factor in determining the performance of its healthcare system. In this regard, I think Singapore has done not too badly. Our average lifespan and health-adjusted life years, these are 2 key indicators, not sufficient, but I think these are 2 main indicators people look at. And for us, we are one of the highest in the world. Yet, we spend slightly less than 5% of our GDP on healthcare, which is less than the average, less than half the average of developed countries. So when I go overseas in WHO or the UN, this is one of the most common questions I get from my foreign counterpart, fellow health ministers. They ask, how did Singapore spend less, but you get more? You get more. They recognize that our health outcomes is actually better than their countries, yet we spend lesser as a percentage of GDP. Truth is, we have benefited from a young population who tend to be healthy, but it is aging rapidly, and this is driving up our healthcare expenditure. 5% will not be sustainable. In the coming years, it will go up. But while we have a good healthcare system and policies today, we still need to adapt to a new reality of an aging population, and there's a lot more room for improvement. Nevertheless, it is useful to understand how different countries manage the iron triangle and the varied results they have produced. As an essential service, healthcare costs need to be socialized. That is, it has to be borne by society as a whole. How this is done makes all the difference to the performance of the healthcare system. So let's consider 2 examples, the UK and the US. Both are complex systems with many factors at play. But let me just highlight one key feature of both systems, which is how they are primarily funded. The UK decided to adopt what we call a single-payer model. That is, the government collects tax revenues and then pay for healthcare. And patients do not have to pay at the point of care. This is almost an ideology of the NHS. Socially, this is very just and very equitable, but there are significant downsides. Just like our hypothetical country, when healthcare is free, the demand will exceed supply. So today, there are 7 million UK patients waiting for treatment. UK healthcare workers work very hard. They feel underpaid. They have gone on strikes recently. The system is under a lot of stress, especially post-COVID-19 pandemic. Government healthcare expenditure is rising, and it needs to compete with other pressing needs, such as education. In the US, on the other hand, private insurance is a major feature of their healthcare financing. Insurance being self-financed through premiums is more sustainable than the single-payer model. There is less competition with other public spending, such as education and defense. Insurance also offers choice to the consumer, who can opt to pay more for better coverage. So it is a more market-based approach to socialize healthcare expenditure. However, in any country, there are rich people who can afford a lot and those who cannot afford anything at all. And for something so essential to life as healthcare, this market-based approach can be perceived as socially unjust and unfair, which is happening in the US. So people who cannot afford insurance premiums can be denied healthcare services, while the rich enjoy 5-star premium service. Whatever the starting point, most countries ended up with a mixed funding system. So while no UK government, the Conservatives or the Labour, will move away from the principle of free healthcare, free at the point of care, actually private insurance is available. Speak to a British, especially a professional, a businessman, ask them about NHS, they will tell you, actually I got private insurance and I go to a private hospital. And therefore, for those who can afford the premiums, they skip the waiting lines and get prompt treatment. In the US, the Obama administration pushed for the Affordable Care Act, what they call Obamacare. So today, about half the national health expenditure in the US is already government funded, no longer that reliant on insurance. Singapore, we have always recognized the pros and cons of subsidies and insurance in socializing healthcare costs, and we decided to use both to pay for healthcare. We also added a third component, which is that of personal responsibility and co-payment through mandatory savings. And therefore, we add it all together. This forms our S plus 2M framework. S for subsidies, 2M is MediSave and MediShield Life. There is no Goldilocks optimal point or restful equilibrium in healthcare. I don't think so. Instead, it is a constant juggling act to complement these funding mechanisms to deliver the best value to our people with the least cost. That's challenge number one. The second major economic challenge in healthcare is to align the incentives of the three players, the three Ps. These are the payer, which can be the government or the insurance company, the provider, namely hospitals, doctors, and clinics, and then the patient who receives healthcare services. Unfortunately, these three players, in Chinese they say 同床异梦. They can share the same bed, but they have different dreams. And in economist jargon, you call it the principal agent problem. To illustrate, insurance companies, they are the payer. They want to keep costs under control. So it's quite well known. Sometimes insurance companies, they resort to denying claims for certain procedures that can be beneficial, and that harms patients' interests. Hospitals, they are often funded what we call fee-for-service. In other words, they are paid based on workload. So they have an incentive to order more tests, more procedures, more surgeries than necessary to get more funding, which is against the payer's interests. Patients, we're all patients one day. We're all supposed to keep ourselves healthy, right? But since healthcare costs are paid for, we have little incentive to do so. And that is against everyone's interests, including ourselves. In Singapore, we have been actively addressing these principal agent problems. The entire policy unit, financing unit of MOH, when I look at their work, they're running around looking at all kinds of rules and policies, actually primarily is to align the principal and the agent. To start with, how do we address that? To start with, MOH, we subsidize healthcare. We also run the MediShield Life National Health Insurance Program. We also oversee the delivery of public healthcare through all our hospital clusters. So we are therefore both the major payer and provider of Singapore, which is probably the best way to solve the trade-off between these two. To further make the public health providers fall in line, meaning our public hospitals, to make sure they fall in line, we practice value-based care at our hospitals. And then we have transited to a capitation funding model. This is itself a lecture, so I won't go into it, but I would say that capitation funding model, if implemented well, it has the potential to eliminate all levels of wastage, at the clinical level, at the disease level, as well as the population level. However, a particularly vexing principal-agent challenge I wish to highlight today is moral hazard, a common occurrence in behavioral economics. How it goes is, if health insurance completely covers my hospital bill, I will use more expensive treatments and drugs. And I don't mind going through more tests and diagnostics, even though they are not all necessary. All the benefits do not justify the costs. We will have experience going to a doctor and they ask, are you covered by insurance? Yes, okay, I think you can go for this test. It does happen. Such behavior is as expected as overeating at a buffet table. I do not know of any Chinese translation of moral hazard. If I translate literally, it doesn't sound very good. But there is a concept called 大锅饭, means a big bowl of rice. It is used to describe an economic system where everyone feeds from the same bowl. But when that happens, everyone tends to work a little less and eat a little more. So this is what is happening here. When every insured patient behaves the same way and inflicted by moral hazard, the collective action will push up national healthcare costs unnecessarily and with a lot of wastage. Sooner or later, the bill still comes back to us in the form of higher health insurance premiums. Remember, in economics, actually, you all know that all healthcare costs ultimately will be paid by the people, one way or another. In this case, it will come back, the wastage will come back to us in terms of higher healthcare insurance premiums. And if it's a market-based system, those with lower incomes may have to forego their private insurance coverage. Moral hazard is particularly challenging in healthcare because it is combined with emotions such as love and concern for our family members. And when that happens, moral hazard is on steroids. We will opt for whatever treatment that may work, however small the chance of success, because we love the patient. And however high the cost, especially when someone else, in this case my insurer, is paying the bill. And there are other aggravating factors, as if this is not bad enough. Pharmaceutical companies, they practice differential pricing of drugs across geographies. That's just how it works. So when there was a single MediShield Life limit, we used to have that, a single MediShield Life claim limit, $3,000 per month for all kinds of cancer treatment. Minimum limit, $3,000 per month for all cancer treatments. There was little reason for pharmaceutical companies to charge us anything less than $3,000, even though the cost of the drug is far less in many other countries. But Singapore, minimum claim $3,000, I charge you minimum $3,000. Yeah. Even though it can cost hundreds of dollars only in other countries. Another aggravating factor, if you have a litigious environment, doctors will order more tests to cover all bases and avoid lawsuits. In healthcare, we call this defensive medicine. Insurance companies rightfully want to rein in moral hazard. In the US, certain insurance companies, they decide to expand their business to also run hospitals. So they forward integrate, where they could therefore build in stronger clinical discipline. Economists recommended setting insurance claim limits and requiring consumers to co-pay part of the hospital bills so that they have skin in the game. And we will think twice before over-consuming healthcare services, since we are co-paying some part of it. But some of the responses of insurance companies end up counterproductive as well. They know that customers always seek greater peace of mind. That's why they buy insurance. Ceteris paribus, a customer will prefer first dollar coverage and higher claim limits. To meet this demand and what customers think they want, insurance companies will offer policies to compensate beyond the claim limit or cover the co-payment. So, as healthcare authorities, we can set certain claim limits, we can set co-payment to rein in moral hazard. Insurers say, okay, fine, but I got this special product. If you buy, you go above the claim limit, you don't need to do co-payment. They call it riders. We have witnessed many instances where winning market share and pushing sales get the better of insurance companies. Our conclusion is that to moderate the excesses and wastage of healthcare, there will likely need to be tighter rules on healthcare insurance. With much effort, MOH has implemented a new regime governing the use of cancer drugs. This is another lecture, but I won't go into it. We are working with all stakeholders on all other possible changes to reduce moral hazard, moderate healthcare cost increases, and make healthcare insurance affordable and fair. And this will be a major area of work. Around the world, a consensus that has emerged among health authorities as a simple way out of all these complexities of managing healthcare systems is that why don't we all just get healthier and we solve all the problems? Given that human beings, we are genuinely concerned about our own health, we can put faith in the Chicago school. All of us will do the right thing. We will be rightfully motivated and self-interested to exercise, eat healthy, quit smoking, go for regular health screening. Unfortunately, things are not that straightforward, and so this is the third economic challenge I'd like to highlight today in healthcare, which is that many individuals are not motivated to do what's good for ourselves and for our society. And this is a classic problem in life and in economics. Rationally, the individual knows that he should watch my social media, adopt a healthier lifestyle, even if it's not mine, somebody else's is fine. But the benefits are far into the future because health habits accumulate and you benefit only far into the future. Meanwhile, he has to give up on steaks, desserts, cigarettes, wine, beer, and binge watching of Korean dramas. If he is healthier in the long run, society will benefit from a lower disease burden. But this is a positive externality that the individual attaches insufficient value to now. That is why we have to incentivize a healthy lifestyle even more. This is the idea behind Healthier SG, to which we are spending about $400 million a year to encourage healthier living. In Singapore, not many things are fully free. We are a land of co-payment. But we made annual preventive care consultation with doctors, nationally recommended health screening, and vaccinations free of charge. One of the few things that you don't have to co-pay. We reward exercise. You don't co-pay for exercise. You reward exercise using digital health apps. This may not be enough if we want to sustain healthy lifestyle for the long term, if we want to become a Blue Zone 3.0, we are thinking of other ways, such as we can differentiate insurance premiums between those with and without appropriate lifestyles. We are considering regulatory measures to reduce the consumption of sodium, which is found in regular salt. For some seniors, their biggest enemy is loneliness. So we are investing in another national program, we call it Age Well SG, to help them build social circles and live an active lifestyle in the community, in their current homes. And we hope to delay and avoid institutionalization of as many seniors as possible, living in a nursing home, their health do deteriorate. We have to treat population health as a social good. Healthcare spending, remember, healthcare spending is mostly an expenditure to repair our sick and injured bodies. I speak from some experience. I don't think it's an investment. I'm just repairing my body. But spending in preventive care, spending in aged care, bears some characteristics of investment, as these can avoid significant future healthcare costs and burden on families and societies. In conclusion, let me summarize the following as what I think are the key economic principles of healthcare. Number one, rely on different ways to support healthcare. Markets have a role, governments have a role, people have a role. Where it is basic and essential, we rely on government subsidy. Where it is advanced, occasional, alternatives are available, we rely more on insurance, including market-based insurance products, to risk pool. For the low income and vulnerable, there should be further safety nets, including philanthropy. And that is why we also have the MediFund, making it S plus 3M. Second principle, create a clear gradient of market signals. Acute care is the most expensive, most susceptible to abuse and wastage, so always maintain that element of personal responsibility. Then step-down and rehabilitative care eases the load for acute hospitals and should enjoy stronger support. Most terminally ill patients would wish to pass on at home in familiar surroundings, in the presence of their loved ones. And I'm glad that with the support of our palliative care providers, home hospice in Singapore is actually free to these patients. Third principle, do not make an enemy of technological advancement. Technological advances such as digital health are helping people practice preventive care and holistic care in an easy, convenient, and even fun way. It has its use, but in healthcare, be mindful, there are also new drugs and treatments that can be beneficial to some patients with certain diseases, but at a very high price. Technological advancement in healthcare is quite different from other sectors. You associate them with better productivity, greater convenience, cheaper price, but in healthcare, often it means new drugs and treatments that can be beneficial to some patients, but at a very high price. Subsidizing these treatments carries a significant opportunity cost because the money can be spent elsewhere, in education, in public transport, in parks, in defense, etc. It is in human nature to make advances. We need to embrace scientific advances in healthcare, but we must always maintain clinical discipline to use technology the right way, and a strong system to evaluate cost effectiveness of drugs, treatments, and procedures. In many instances, existing care options are actually good enough, and that is why Singapore has now set up a robust system of health technology assessment. Fourth and final principle, have time on our side. This means being prepared to invest in holistic and preventive care and build up population health for the long term. The interventions to shape better lifestyles are always simple and much cheaper than running hospitals. Healthcare, it runs the length and breadth of economics. Every economic phenomenon, every distortion that we have studied, every challenge that we have studied can probably be found in healthcare. How exciting. A good healthcare system is fundamentally about the skills and passions of doctors, nurses, and healthcare workers, and a culture of good health amongst the population. And these are things that cannot be measured through our GDP, cannot be measured in dollars and cents, and which money cannot buy. But for everything else, there is healthcare economics. It is therefore my hope that our economists devote more time and attention to healthcare economics. By explaining some of the intricacies and complexities, I hope I piqued your interest. You can help whether in strategizing the allocation of scarce resources to demand, how to resolve principal-agent problems between the 3 Ps, or using behavioral economics to nudge people to adopt healthier lifestyles. There are many possibilities, endless possibilities, so much so that MOH, we are thinking of setting up an economics office with a chief health economist. That's still in the works. Economics and economists have much to offer in healthcare, and I think it will be a fulfilling and rewarding endeavor that can help shape the future of a super-aged Singapore to bring quality of life to Singapore beyond our GDP. Thank you.